Evaluation of pneumonia from transition to translation. Please read those answers. عندنا حاجات كتيرة قوي في الوصف دي فحبينا ان احنا نقول لكم في برزنتيشن عنها. السلام عليكم. اولا يعني طبعا جزيل الشكر للفرصه الكبيره اللي اتيحت لنا النهارده كاطباء رعايه اطفال مستشفى مشيط البكر. احنا جوه تواجدين مع حضراتكم النهارده في اول مؤتمر لينا. الف شكر للحضور الرائع الجميل من اساتذتنا وزملائنا والمشاركه الايجابيه الرائعه من اساتذتنا الكرام. نورتونا ويا رب ان شاء الله يكون مؤتمر يعني ناجح ومثمر وعلى قدر المسؤوليه باذن الله. From consolidation to capitation, we are going to talk about pneumonia pneumonia clinical cases from our PRC. First, as a rapid introduction, what is necrotizing pneumonia? Necrotizing pneumonia is a rare complication of community-acquired pneumonia and is characterized by catastrophic illness and a prolonged hospital stay and the disease course. It is characterized by the development of necrosis, liquefaction, cavitation on the lung parenchyma by an infectious pathogenic agent in the child with community-acquired pneumonia. Necrotizing pneumonia may progress rapidly in previously healthy children despite early and adequate treatment of the initial community-acquired pneumonia. Although necrotizing pneumonia is still deemed to be rare, but the incidence of pediatric necrotizing pneumonia has increased. Primary history, necrotizing pneumonia was first described in adults in 1940s, and around 1994 the instance was reported in the children, with a gradual increase in the reported cases stemming partly due to increased awareness and improved diagnostic techniques. What are the positive pathogens? The most common pathogens reported in the children with necrotizing pneumonia are Streptococcus pneumoniae, approximately 60%, especially serotype 3 and serogroup 19, Staphylococcus aureus more than 20%, Mycoplasma pneumonia, Klebsiella pneumonia, Pseudomonas, viral causes as an adenovirus, influenza, parainfluenza, fungal infection, or co-infection. According to epidemiology, last year reported that 3% of cases of community-acquired pneumonia in UK have complications, but nearly more than 4% of community-acquired pneumonia are necrotizing. Children aged less than 5 years have the highest incidence of community-acquired pneumonia complication, and the retrospective study shows the incidence increasing during the past 20 years. In our PICU in مشيط البكر Hospital, وده شغلنا احنا بقى. In the last year, we have recorded 25 cases of necrotizing pneumonia. According to demographic data, 21 cases were less than 6 years, 4 cases were more than 6 years, 14 cases were males, 11 cases were females, 19 cases were less than 20 kilograms, and 6 cases were 20 kilograms. Clinical presentations اللي كانوا جايين بيها 21 cases were presented with prolonged fever, cough, tachypnea, 4 cases were presented with fever, abdominal pain, and persistent vomiting. Our investigation tools اللي احنا بنعملها laboratory, complete blood counts, inflammatory markers, and CRP, ESR, LDH protein, D-dimer, and sometimes cardiac enzymes. Cardiologically, عملنا X-ray, CT chest, and chest ultrasound. Radiological finding اللي كانت موجودة كانت in the form of lung consolidation, pleural effusion, empyema, pneumothorax. The right lung was affected mainly in 9 cases, left lung كانت affected mainly in 10 cases, and bilateral affection in 6 cases. According to types of ventilation اللي العيانين دول احتاجوها, 8 cases needed conventional mechanical vents, 11 cases needed high flow nasal cannula, and 6 cases needed mask, oxygen, and cannula. according surgical interventions and mortality. 19 cases needs no surgical interventions, 3 cases need surgical interventions, and the mortality was 3 days. دي X-ray، بعض الإكس-رايز من العيانين بتوعنا احنا في ال PICU on presentation. ده عيان جاي من بيته، جاي بهذا القدر من السيفيريتي. This is community acquired not hospital acquired pneumonia. Complete affection bilateral more على الرايت سايد pneumothorax lung collapse. left lung AV تقريبا مش موجودة. severe affection على الليفت lung. نفس الكلام الليفت lung severely affected في our patients. اللي في النص دي فيها tension pneumothorax with lung collapse، وزي ما قلنا ده on presentation left lung severely affected. مقاطع من ال CT to our patients shows necrotization with cavitation اللي موجود على ال right side of the lung, right side, poor effusion on the left lung, severe affection على right lung, again necrotization, cavitations على right lung. Now we are going to present 2 cases from our PICU cases. Case number 1. Muhammad, 3 years old, male patient, 4th order first of non-consumption experience with no significant past medical or surgical history. Presented complaining from fever, dyspnea, tachypnea, abdominal pain of 15 days duration. Sought medical advice, received the medical treatment in the form of antibiotic injection, Cipotex and Unacin for 7 days, but he didn't improve and was referred to our ER with respiratory distress grade 3. According to past history and family history, no recurrent hospital admissions, no history of asthma or recurrent wheezy chest. He was vaccinated with the obligatory vaccines up to date and normal development according to the age. By examination, generally the patient logged L, pain, toxic. In heart rate can 165, respiratory rate 60 per minute, capillary filling time 2 to 3 seconds, blood pressure 100/60, saturation can 88% on the room air, 94% on the nasal oxygen at 2 liters per minute. Chest can be marked diminished their entry on the right side, coarse and fine cracks bilateral with subcostal and intercostal retractions. Cardiovascular can normal heart sound with no audible murmur. Abdomen can be generalized abdominal pain, but the abdomen was lacked just slightly distended with audible inside sound, no organomegaly, وباقي systemic examinations كانت normal. الانيشال انفستيجيشنز اللي عملناها كسي بي سي هاي تي ال سي 25.5 مللي نيوتروفيلز هيموجلوبين 7.4 بريكل 579 السي ار بي كان 147 اي اس ار 50 ال دي اتش 380 الدي دايمر كان 1.5 الليفر فانكشن كاي سي وال تي كانت نورمال الالبومين كان 2.7 ودي ال جي اون ادميشنز والاكس راي اتعملت. حقيقة لما عملنا الاكس راي كان فيها غريبة شوية، كان في شكل ديزاين تو رايت سايد لكن كان في شادو على الليفت سايد ما كناش قادرين نحدده قوي هل دي لارج نيماتوسيل ولا دي ايه بالظبط؟ عملنا سي تي. وده كان شكل السي تي بتاعته. left sided hydropneumothorax. Again, مقاطع من السي left sided hydropneumothorax. CT chest كان فيها evidence of left sided hydropneumothorax with left lower lobe segmental consolidation collapse with atrial decapitation. The picture was suggestive for necrotizing pneumonia complicated with hydropneumothorax. Chest X ultrasound ده عملناه كان فيه left lung consolidation, cavitation, septation with turbid pleural fluid collection. The patient was admitted on nasal oxygen at 2 liters per minute. Chest tube was inserted on the left side, and a sample from the pleural fluid turbid was sent for cytology, chemistry, and cultures can be the chose high LDH 4,200, serum LDH 380, glucose can 20 milligram per deciliter, white blood cells كانت 6,300, but the culture was negrous. Patient was admitted on Maripin and vancomycin. Dexamethasone was added at 0.15 milligram per kg per dose, and antibiotics were escalated according to the general and chest condition of the patient. He received linezolid and diflucan. The patient was admitted in our PICU for 42 days. After 3 weeks, it was difficult to remove the chest tube due to persistent air leak from the chest tube, recurrent recollection suspecting bronchopleural fistula. Cardiothoracic consultation recommended to apply negative suction pressure to the chest tube. After 20 days of suction, the patient responded and the chest tube was removed. Is currently following up as an outpatient. دي اللاب انفستيجيشنز بتاعته البروجريشن بتاعها during admission كل الاكيد فيز رياكتنت الحمد لله اتحسنت جدا كتي ال سي كي اس ار سي ار بي دي لاينرز الكالتشر بتاعت الولد ده اولسو كانت نبرس. ده شكل الفولو اب سي تيز توضح على الليفت سايد شكل النيكروتايزيشنز والكافيتيشنز اللي كان موجود. again this is severe necrotization cavitation على الليفت سايد. ده الفولو اب سي تي الاخير وكان شاوز امبروفمنت واضح جدا الحمد لله على الليفت سايد. اخر سي بالظبط ده عن قرب ليها الليفت سايد اتحسن بشكل كبير جدا بالاكس راي اون ذا شارج وكانت ماتش كتر. ودي الاكس راي في الفولو اب فيزيت اللي عملها لما كان بيتابع في الكارديوثوراسيك تيست. The second case now will be presented by Dr.Hend. اتفضلي.
It's my honor to participate in this conference. Dr.Hend Adel. I will present our case Yahya. Yahya, 4.5 years old, first order person from non-consanguine parents, fully vaccinated with no significant past medical history. The condition started 5 days before admission with diarrhea, vomiting, fever. Then he developed Dr. Kholoud tachypnea. Mother took medical advice and he received oral antibiotic amoxicillin clavionic, but it didn't improve. Patient presented ER with fever and allergy. By examination, generally toxic, febrile blinding, vital data, heart rate 150, respiratory 55, temperature 39.5, saturation on the room air 86%, 91 on the nasal oxygen. Chest, by examination, the chest diminished the entry on the right side, discarded wheels, crepitation, and subcostal retraction. As regards the heart and abdomen, no abdomen detected. Initial investigation, TDC of 17 milligrams and CREAT 0.6, CRB about 90, as regard another lab with the normal. We did chest X-ray, our right side consolidation, upper middle loop with minimal pleural effusion, small rim of pneumothorax. A chest ultrasound done, minimal pleural effusion on the right side, served with right-sided consolidation patch with air bronchogram. As the CT chest revealed, right apical posterior lung zone and multiple B lines that donating consolidation patches, moderate cerebral pleural effusion. And the CT done in the ER. That's showing cavitation and consolidation with minimal pleural effusion. Patient admitted on high pneumonia, oxygen 60%, flow 15. After 4 days, he developed tension pneumothorax and chest tube was inserted with a large amount of yellowish turbid pleural fluid. Was coming out, the sample was taken for analysis. As a chemical examination, glucose low 10, LDH 500 to 177, the protein 2.8. As microscopic examination, mainly white disease 8.5. Mainly polymorph, no acid fast bacilli, absent and die, agriculture of pleural aspect showing Klebsiella sinus septocolistin. And this is the chest X-ray at the first one. She showed tension pneumothorax, and then the second one we insert the chest tube, and the third one we insert the second chest X-ray after inserting chest tube. As a medication, patient admitted on ceftriaxone, vancomycin, which means excreted to Maryland, linezolid, deflocaine, and zinc colistin was added according to culture of pleural aspect. The chest tube was fumbling with continuous persistent air leak, and according to the cardiothoracic consultation, chest tube was connected continuous negative suction from 50 to 100. After 1.5 months, patient was consulted by Academic Institute of Cardiothoracic Surgery in Shams University, and they recommended to continue on negative suction and antibiotic, and there was no need for surgical intervention. The patient remained on suction for 2 months with gradual improvement of the general and chest condition. Finally, he responded and chest tube was removed. Then he discharged to continue follow-up with cardiothoracic clinic. This is the table showing a lapse of the patient from the day 20 to 28 days of May and 13 June. There is improvement in TCA count from 17 to 11 to 7, as acute phase reactant CRP was above 90, then 75, then 5. As another lapse was within normal or to the duration of the disease. This is the cause of the first CT done in the ER, showing cavitation, consolidation, and minimal pleural effusion. And the second chest CT done, and this collection of the hair and this fibrosis and consolidation. And this chest CT, we consult the Cardiothoracic Institute of Academy, and they consult to continue on the suction and no need for cardiac intervention, surgical intervention. And this is the next CT done. They're showing a rim of pleural effusion and consolidation, but better than before. This is the last CT done to the patient. There is collection of air, and there is a patch of consolidation, but better than before. And the chest X-ray. This is the chest X-ray done before extending of the chest tube and pull removal. This is the first chest X-ray done after removal of the chest tube. And this is the last one. The patient did chest X-ray without the chest tube. There is improvement in the lung condition at the right side. There is a patch of pneumonia, but the general condition of the patient was a good general condition with related oral feeding, a cool acute phase reactant type visit. Clinical tests: necrotizing pneumonia, also known as cavitating pneumonia, in the life-threatening complication of community-acquired pneumonia. It is a severe form of lung disease that can cause abscess and cavitation to form within lung tissue. Common complications associated with include parapneumonic effusion, bronchopleural fistula, or pneumothorax. The pathophysiology of necrotizing pneumonia is not well defined, but it is believed to be related to inflammatory process caused by toxins produced by pathogen or due to associated thrombus or vasculitis. The primary treatment for necrotizing pneumonia is supportive care and appropriate antibiotic therapy. In case the patient's condition doesn't improve, surgical intervention may be necessary to save their life. Thank you.
I will take the chance to congratulate for our peak unit associated background as being one of the most important peak unit over the government of Cairo, and for these fruitful lectures and gathering of most of the eminent professors. Now I have the proud to introduce our eminent professor, Dr. Adel, for lectures, Pitfalls in Pediatric Practice.